Good afternoon, everyone, and welcome to today's webinar titled Management of Abnormal Cervical Cancer Screening Tests, a discussion of case studies from Indian country. I'm Michelle Edelman, the Clinic Systems Coordinator at the American Indian Cancer Foundation, and I have the pleasure of introducing our speaker today, Dr. Amanda Bruegl. Dr. Bruegl is from the Oneida and Stockbridge-Munsee tribes, and she works as a gynecologic oncologist at the Oregon Health and Science University. Dr. Bruegl specializes in the diagnosis and treatment of gynecologic cancers. She enjoys developing relationships with their patients and their families throughout the course of their cancer treatment and has a research interest in cancer prevention and improving access to treatment in the American Indian and Alaska Native population. In her spare time, Dr. Bruegl also enjoys hiking, camping, reading, and traditional Native American beadwork. This is the third and final webinar in a three-part series dedicated to women's health-related topics. We have allotted 1 hour for today's webinar, and you will have opportunities to ask Dr. Bruegl questions. If you have a question, please type it in the chat box, or if you're watching live with us on Facebook, enter your questions in the comment section. Depending on the question you ask, Dr. Bruegl will either answer it live during the webinar or send you a follow-up email with more detailed information. If you have questions after the webinar, please send an email to health@aicaf.org, and we will send a follow-up email answering the questions. Dr. Bruegl has graciously offered to accept questions about abnormal cervical screenings until this Friday, July 27th, which can also be sent to the health@acaf.org email. Be on the lookout for a brief survey and an email containing the recording of today's presentation. I will now let our guest speaker, Dr. Bruegl, take over so she can present with you with new information or give you a great refresher.
And thank you for joining me again. There are going to be some review items from our prior webinars if you weren't able to join us, and maybe just a little extra reinforcement of some of the core principles. Next slide. So we're just going to do a brief review of screening guidelines and some clinical resources for you as you navigate women's healthcare in the clinic. Next. So cervical cancer screening guidelines are constantly changing, but the current guidelines for age less than 21, no screening at all. From 21 to 29, it is recommended that pap smear or cytology happen every 3 years without HPV testing. From ages 30 to 65, there are multiple options. The preferred method currently is HPV and cytology co-testing every 5 years. If HPV testing is not available at your site, cytology alone can continue every 3 years. Or the newest set of guidelines includes HPV testing occurring every 3 years. After age 65, no screening is necessary for cervical cancer. However, for a woman with a history of moderate or severe dysplasia, CIN 2 or 3, or a history of adenocarcinoma in situ, screening should continue for 20 years following the diagnosis, regardless of age. Next. Primary HPV screening is a newer modality, and here is the algorithm that's been proposed for people using this route. So at this point, a cervical HPV sample is obtained. If that is negative for high-risk HPV, the woman can continue with routine screening. At this time, every 3 years for high-risk HPV is considered the acceptable screening frequency for this population. If the high-risk HPV screening is positive, subtyping for either 16 or 18 versus the other 12 high-risk HPVs is recommended. If a patient is noted to have high-risk 16 and 18, proceeding to colposcopy is the standard. If it's one of the 12 other high-risk HPV subtypes, proceed with a cytology or pap smear. If the pap smear is negative, you can follow up again in 12 months. If it shows ascus or greater, then proceeding with colposcopy is the current recommendations. Next. So last time we talked about this, but if you weren't able to join us for our second webinar, there are special guidelines for cervical cancer screening in women who are known to be HIV positive. Next. So cervical cancer screening with cytology should begin within 1 year of diagnosis, and this does include women less than 21. So this is the only time that you would do something in a younger woman. So for example, if she was diagnosed with HIV at age 17, you would start pap smear screening starting at age 18. Next. Additionally, if a baby is born with an HIV positive mother and the virus is transmitted, you don't start pap smears, obviously, and at that point, you continue to follow the child throughout their adolescence. And once they are sexually active, you would start pap smear screening within 1 year of sexual activity. Next. Additionally, unique to the HIV positive population, cervical cancer screening should continue throughout the lifespan of the individual. So you do not stop at age 65, you continue indefinitely. Next. One really useful resource for in the clinic and on the go is the ASCCP app. It has both guidelines for screening as well as guidelines for management. You can put the patient information such as age, HPV status, and how you are screening into the app, and it will help lead you through the published algorithm to help you determine what's the best management strategy. Additionally, one other thing about the app that is nice is that it will update as soon as guidelines update. It costs about $10 or $11 at the App Store, but I use this exclusively for all of my patients. And if that is within your resources, I highly, highly recommend it. Okay, next. Okay, some commonly asked questions. Next. So one question I received was, can you discuss screening versus management for cervical cancer and dysplasia? Next. So when we think about screening and early detection, I think about it in terms of prevention tools. So HPV vaccination is what we would call primary prevention. So we are trying to help protect the individual against acquiring HPV, which is known to participate or influence the development of cervical precancer and cancer. Additionally, the pap smear is a secondary prevention strategy. So by utilizing the pap smear, you are trying to detect pre-invasive lesions, so cervical precancer, dysplasia, versus early stage cervical cancer, so that you can prevent morbidity and mortality from advanced stage diseases. Next. So in terms of HPV vaccination and primary prevention, there are 3 FDA-approved vaccines in the US. I want to call your attention to the one on the far right, because I think most centers, I believe Indian Health Service is using this almost exclusively. It has coverage for HPV subtypes 6 and 11, which are not known to be associated with cervical cancer, but they are associated with the most common types of genital warts. As you can see, all 3 vaccines do protect against 16 and 18, but with Gardasil 9, or the 9-valent vaccine, you get protection against 5 additional types of high-risk HPV that have been associated with the development of cervical cancer. Next. The HPV vaccination schedule has gone through some adjustments over the past year. It used to be that all people, regardless of age, who are eligible would require 3 vaccines. There is now recommendations from the CDC and the Advisory Committee on Immunization Practices that there are certain individuals who only need to receive 2 of the vaccine doses. Individuals who are eligible for this are aged 9 to 14, and as long as they're healthy. If you have a 9 to 14-year-old who has immune compromise due to juvenile rheumatoid arthritis or a transplant, they would be triaged into the 3 vaccine series. Ideally, an interval between doses would be about 6 months. However, follow-up can sometimes be complex, and you do not need to restart the vaccine series over. You just continue where you left off and try to keep the patient on track. Next. In terms of secondary prevention and the pap smear, so again, the pap smear helps detect precancerous lesions and early stage cancers. This graph just shows sort of the trend among different races in the US since the pap smear started to become part of routine clinical practice. On the far left, you can see that the rates of cervical cancer were much higher in the early 70s. And then as the pap smear became part of the annual well-woman exam and part of women's screening care, the rates of cervical cancer have gone significantly down. Next. So HPV vaccination and pap smear screening is, those are screening tools. If we're talking about diagnostic tools, typically we're talking about either the LEEP, which is pictured on the left, or a cold knife cone, which is pictured on the right. Both are acceptable forms of removing precancerous lesions or lesions that are thought to be early stage cancers. With the so the LEEP can be offered in the office in well-selected patients. You use cautery to remove the abnormal appearing tissue. The cold knife cone can be done in the operating room, and the patient is usually under conscious sedation or full general anesthesia. And so depending on your patient population and your resources, you can pick whichever modality seems to work best for you. Next. Okay. Another question we had, what tips do you have for working with patients who have a history of sexual trauma? We could probably spend a whole hour on this, but I've tried to consolidate just a few things that I've picked up from my own clinical practice. Next slide. So I think the first and most important thing when you have a patient who's experienced trauma is just to slow down. I think in our busy practices, when we have 15 minutes per patient, we become very focused on, let's get you up to date, let's get your pap smear, let's talk about these things. But really, if you know a patient has this history, slow down, because just knowing that this exam is coming is a real trauma. At the annual woman exam, it's actually very, very important to ask the question. Asking our patients to just volunteer this information is not going to help us know. So, it takes some practice to get comfortable with this question as a provider, but I try to make a point with every new patient to my practice is to ask, do you currently or have you had in the past a history of sexual or physical trauma? Some people will have had trauma and will say no, and that's fine. But you've asked, and they'll realize that you think it's important. And that may be just the beginning of building that trust relationship with them. For patients with a known history of trauma, I will add an additional 15 to 20 minutes to standard visit times so that we can really unpack and help her feel in control at each visit. So a 15-minute follow-up visit is not ideal for this particular patient. I will do 30 to 45 minutes so that I can continue to build trust and build rapport with her so that she will keep coming back to see me. Additionally, I think it's very important to describe, what do you plan to do today while the patient is dressed? Often when we're in all business mode and we're trying to get through the clinic, we'll ask our MAs or our nurses to have the patient be undressed so that when we walk in the room, we can start. I think when there's known trauma, it's really, really helpful for them to see you, have a calm experience with you, and make sure that you talk about, this is what I plan to do today. Do you have any questions or concerns? Additionally, I empower the patient to tell me to stop at any point during the exam, and that we can always redo it another day. I think helping the patient feel like they're in control during this really vulnerable time helps them to feel like, okay, I can do this because I can say stop. And if they do say stop, just stop. In my practice, I have the benefit of doing exams under anesthesia, and I know we don't all have that. But if that is something that you're able to do, in some patients, that is the best way to get them the care that they need. Next slide. Okay, here is the dreaded, what if she says yes? Like, okay, I asked the question and she said yes. Now what do I do? I think the first thing to do, ask if she's currently safe in her relationship and at home. If there are acute issues, I think the pap smear is the least important thing in her day. And working with your local resources, domestic violence resources, social work, develop a plan. Are there children in the home? Does something need to be done from a child safety standpoint? More often than not, it'll be a history of trauma, but they're currently safe. And that's where I kind of really, again, slow down the visit and ask, what has she done for her own healing? Has she ever talked to someone? Does she want to talk to someone? And I just ask an open-ended question, like, how can I be helpful in this for you? What can I do? And then just really do some open listening. There's no clear-cut way to get through, or there's no, what's the word? There's not a blank template that works for everyone. It's really just spending a lot of time listening, making sure that your body language says, I have time for you, and being open to letting her be in control. Next. All right. I think this question happens in a lot of clinics. How do I get the patients to show up for their follow-up colposcopy? No-shows are really common, and I think that there is a lot of concern and worry on a patient standpoint, and we can talk about some ideas to help get them to follow up. So next slide. So first, kind of backing up a little bit, in the era of all this great screening, who gets cervical cancer? one of the most common things is a woman is not presenting for screening. And as providers, we can't do too much about that. We can get the word out and we can have advocacy in the communities. But the next 2 points are an opportunity for providers to help. Okay, so if women aren't offered screening at a healthcare visit, so let's say they come in to, have their throat swab for strep, and you notice that they're due for their Pap smear, try to take opportunity at that visit to get them updated or offer an appointment for that. So it's on us to help offer screening and keep track. Colposcopy for an abnormal screen isn't performed, and that can be both patient and providers. So helping to make sure that we really know the guidelines and when they should be following up and how, that's what we have control of as providers. And then from the patient perspective, there's a lot of barriers and a lot of things that can impact that. Next. I think one thing that's really helpful is patient education. Like, what is colposcopy? Can we demystify this? What's happening? Next slide. Next slide, okay. So many patients have no idea what it is. So I sit down at the beginning of the visit, and again, everybody, you're as you were, everyone's got their clothes on, we're just gonna talk about the Pap smear, and we're gonna outline the day or the visit. And so I spend about 10 minutes discussing the procedure, talking about the equipment. Many women see the colposcope and they see that it is huge and they think that this is actually going to go inside of them. So one of the first things I say is that this is not going inside your body at all in any way. And I explain to them that this is going to start out like a Pap smear. You're going to have a speculum in place. We're going to look at your cervix. And then I'm going to put vinegar solution. I think vinegar sounds better than acetic acid. Many women are triggered by the idea of someone putting acid in a very private area. So I say a vinegar solution to help me visualize things better. I refer to the colposcope as binoculars for the cervix. It's something to just enhance my view. And so once we've done an orientation to equipment and the steps of what I'm going to do, I ask the patient, once we start to proceed, I ask if they're okay each step of the way. And I just narrate, this is what I'm going to do. No one likes surprises, and a lot of people like to have an idea of what you're doing as you're doing. If I think that I'm going to need to take a biopsy, I'll warn them this is going to be crampy. I also tell them what I'm seeing as I'm seeing it, like, oh, I see some just mild white changes. This is nothing to be concerned about. Or if your cervix was a clock, I see something around 3 o'clock that I think I'd like to biopsy and look at further. And really just letting them know what you're going to do. And then when you're completed with the procedure and they're dressed again, I like to come back for a quick wrap up. I draw a little picture and say, this is what I saw today, and this is the follow-up plan. So I think, again, keeping the patient in control, educating them of exactly what you're going to do is really important for empowering them and engaging them in the care of themselves. Next slide. In terms of strategies to increase the follow-up, there was a patient navigator program that was performed at a facility, I think on the East Coast. And it was kind of an all-comer academic clinic. And they had high no-show rates. And they had a nurse navigator who was a part of every abnormal Pap visit. And they would come with the patient and advocate them and help with education and to be there with them to help provide them some advocacy during this process. If you can hit next. They found that their navigator decreased the no-show rate by up to 50%. So just having a champion that's not the medical personnel per se was really, really helpful in decreasing their rates. In this region here, the current chief medical officer for Indian Health Service region, he would actually have a patient come in for a discussion visit. And they would talk about the Colpo, but they wouldn't do the Colpo that visit. And then he would schedule the Colpo visit for a week or two later once he'd had a chance to talk to them. And he found that by having an education, low stress environment, that actually increased his rate of colposcopy significantly. And so those are just some things you can think of to help with that. Next. Okay. So next question, how does a history of a LEEP or a cold knife cone impact a woman's future pregnancy? Next. So if you remember the slide from before, where we take a portion of the cervix to help remove dysplasia, you can see that on the left, you can see that a portion of the cervix is taken. Depending on how severe the dysplasia is, that cone can be either relatively small or quite large. and a significantly shortened cervix can increase the risk for preterm labor or preterm birth in future pregnancies. Next. So at the time of colposcopy or when they have a follow-up for a procedure, it's important that the provider who's doing the procedure briefly talk about there are some risks associated with this and that they know. If a patient is not pregnant but considering pregnancy, that is the time where you can refer to either MFM, a maternal fetal medicine physician, or an OBGYN for consultation. I feel like more often than not, patients come to us with a known pregnancy. And so at the time a confirmed viable pregnancy is known, you can also do referral then in the first trimester. There are things that we can do now that can help decrease the risk of preterm birth and preterm labor that are important for the patient to know about. So often what the MFM or the OBGYN will do is a cervical length measurement around 16 to 18 weeks of gestation. If it's found to be a shortened cervix, women can be prophylaxed with either vaginal progesterone to help decrease that risk of preterm labor and preterm birth, or if at the beginning of pregnancy her cervix is markedly shortened, there's a surgical procedure called a cerclage that can be given to certain candidates to help reduce that risk. Next. Okay, I'm going to spend some time talking about how you manage different types of abnormal pap smears. And this is coming from the guidelines, but these are the things that I feel like I get the most pages from my colleagues about in terms of now what do you do? So the first one would be, how do you manage an unsatisfactory pap smear? Next. So this happens in about 1% of all pap smears. Okay. If HPV testing has been performed and it is positive for high-risk HPV, you can proceed with colposcopy, or you can repeat the pap smear in about 2 to 4 months. If the HPV is negative or testing was not able to be done for some reason, you can repeat the pap again in 2 to 4 months and reassess. Next. Okay, what if the pap smear is negative, or NILM is what you'll often see on paps, but there's no endocervical cells or transformation zone? One thing that I want you to look at is the fine print in the pap smear. Often you'll see in all capitals NILM, which essentially is a normal pap smear, and in fine print it'll say no transformation zone. So it's important to look for this piece. Pathologists should be saying transformation zone present or absent. Okay, next. So we have a normal pap and no transformation zone. This is present in about 10 to 20% of all pap smears. This is more common in older women because the transformation zone tends to be tucked up more in the endocervical canal, whereas normal menstruating women, kind of the 20 to 30-year-old population, you can often see that visible ectropion. One thing that I do in almost all of my pap smears is I get the standard pap, but then I use a cytobrush in the endocervical canal and send those that sample along with the pap smear in the hopes that I decrease the number of no transformation zone paps. You can triage this result based on age. So if a woman is between 20 and 29 and has a normal pap and no transformation zone, you can continue with routine screening with a pap in 3 years. For somebody who is 30 and older, HPV status helps us to really triage these results. So if HPV is negative and there's no transformation zone, you can continue with co-testing at a shorter interval. So co-testing in 3 years instead of 5 years. If the HPV status is unknown, you can do co-testing again in 3 years. And if it's HPV positive, it's recommended that co-testing occur in 1 year. Next. All right, what if it's a normal pap, but there's HPV positive found? Next. Next slide. Okay. Okay, so you go back one? This looks like it came back a little funny. Okay, normal pap and HPV positive. Okay, let's go forward. Okay, so if HPV is, sorry for the top, it just looks a little discordant, but if it's HPV testing is done and it's negative unknown, co-testing in 1 year, HPV testing is positive, if you can do subtyping, this is incredibly helpful. So if it's high-risk HPV positive and it's 16-18, proceed with Colpo, because most cervical cancers in this country are due to 16 and 18. If it's a high-risk HPV pap smear, but it's not 16 and 18, you can do co-testing at 1 year's time. If you don't have HPV subtyping available to you, you can do co-testing in 1 year. And even though the guidelines say this, I actually, I think that colposcopy, just from a professional opinion standpoint, I think colposcopy is also reasonable if you think that the patient is at higher risk or might fail to follow up in a year. Okay, next. Okay, let's talk a little bit more about ascus paps. I feel like these are the most frequent and most challenging to wrap your head around. So next slide. So atypical squamous cells of unknown significance. That translates to slightly funky, but not totally weird. About 1/3 to 2/3 of ascus paps aren't actually due to HPV-related changes. Things like inflammation, BV, yeast infection can cause abnormal cells that aren't actually due to something concerning like HPV-related changes. And so HPV is incredibly helpful at triaging these ascus paps and decreasing the amount of patients who need to be seen for colposcopy or other procedures. So if HPV testing is performed and it's negative, you can co-test again in 3 years' time. If HPV testing is positive for high-risk HPV, then proceed with colposcopy. And in this situation, if you do not see a visible lesion, ECC is recommended. Next. What if the patient's already had a hysterectomy? Do I need to continue the pap smears? Next. So if a patient has no history of moderate or severe dysplasia, so it's CIN2, CIN3, or adenocarcinoma in situ, no further screening is necessary. It's sometimes difficult when patients transfer to different practices to really get an idea. Sometimes I'll ask questions of, have you ever had a colposcopy before, where they look closely at your cervix? Have you ever had surgery on your cervix before? That helps me kind of tease out what they might have had in the past. If they say they've had a surgery on their cervix, I will kind of be more conservative and sort of treat them like they've had a moderate or severe dysplasia and continue pap smears. So if there's a history of CIN2 or greater, you're going to continue with age-appropriate screening for 20 years after that dysplasia diagnosis, regardless of their current age. So if they had CIN2 that was treated at the age of 55, you would continue with age-appropriate screening until they were 75 years old. Next. Okay. And I will leave it to the women of the American Indian Cancer Foundation here to help us with our wrap-up.
All right, thank you so much, Dr. Bruegl, for this great information and for collaborating with us for these past 3 webinars. And I would like to thank all of you for joining this 3-part webinar series, again, in partnership with the American Indian Cancer Foundation and Dr. Amanda Bruegl. Please be on the lookout for more webinar collaborations between ACAF and Dr. Bruegl in the near future. And then also we will be sending a follow-up email with the a recording of the presentation today, as well as an evaluation that we would really appreciate if you could take just a few moments to fill that out. Again, if you have any questions for Dr. Bruegl or for ACAF in general, please send them to health@acaf.org. And thank you and have a great rest of your day.